want to intro yourself quickly? Tell us about yourself.
Assalamu alaikum, sir. Thank you for giving me this opportunity. I'm Dr. Babar Qureshi. I have recently passed my FCPS board exam. I have trained from Liaquat University of Medical and Health Sciences. It's a pleasure, it's an honor, and it's a big responsibility presenting topic today in front of such big, huge big names in the neurosurgery. And so I would like to thank you, all of you. Thank you so much, sir.
Thank you for doing it. It's a pleasure for all of us. Babar, I think you should get started.
Yes, sir. I'm trying to share my screen.
Okay. So, Ahmed, how many people from Yemen and Middle East on board right now?
I think there is many, at least more than 20 or 25. But,
good. We'll have more join from Pakistan soon also. Yeah.
Yes, usually it's more, but as I told Professor Famita before, that now in Ramadan, it's 7:30 now, and iftar is at 7, so some may be going as late.
I know. We were also trying to wrap up iftar and dinners and all of that to get started, but I'm glad you guys are doing this.
Yeah, and it's an honor to have you, Professor, with us.
Dr. Baba, can you start, please?
Okay, Bismillahirrahmanirrahim. To start with the beautiful name of Allah, the most merciful and beneficent. Today, the topic of presentation is anatomy of the neck, and then we'll talk about the subaxial spine. So objectives of today would be to study the anatomy of the neck from anterior view, posterior view, surface markings, muscles, important muscles of the neck, important organs, neurovascular structures, and in the end, we'll talk about the subaxial spine. So why understanding the anatomy of the neck is important? It is basically the check post connecting the head with the rest of the body, the important structures that are passing from the head. Just for example, the brain that becomes the spinal cord by the brain stem, and the important structures that pass through from the head to the rest of the body. So it's very important to understand the anatomy of the neck. It is important neurovascular structures pass through it, and it is the most mobile part of the spine, cervical spine. That is the most mobile part. So understanding its anatomy, the important joints, and to understand the pathologies would be very important. Important vital organs like pharynx, esophagus, larynx, trachea, all are situated in this region. So starting with the surface marking, when we see the neck, the most important muscle here to locate is the sternocleidomastoid muscle. When we move our neck toward the opposite side and give some pressure, so we can see the sternocleidomastoid muscle here in this picture, as we can see. Sir, is my cursor visible on the screen?
Yes, we can see it.
Okay, so here we can see the two heads of the sternocleidomastoid muscle arising from the one from the sternal head, second one from the clavicle, and both join together and will be attached to the mastoid. Here on the picture on the right side, we can see the actual picture of the muscle, sternocleidomastoid muscle. So by knowing this surface marking, we can divide the neck into two important triangles, that is the anterior triangle and the posterior triangle. We'll see in the subsequent pictures. The area, the potential space between the two heads of the sternocleidomastoid muscle is again very important to locate the internal jugular vein, where we can puncture the internal jugular vein. Other important landmarks, surface marking in the neck, is the thyroid cartilage. It is the most prominent part in the anteriorly situated in the neck, also known as the Adam's apple. Now, this basically signifies the thyroid cartilage, and it correlates with the cervical C4 and C5 vertebrae. Just below it, we can also palpate the cricoid cartilage. Just below it is the cricoid cartilage, which correlates with the C6 vertebra. Now, in this picture, we can correlate these important structures. If we start counting the cervical vertebrae from C1, R, C2, and C3, as and the at the level of the C3 here, we can see two important structures. One is the hyoid bone, which is hidden here behind the mandible, and we can also see the mandible. So these are the two important structures that lie at the level of the C3. And when we come at the level of C4 and C5, we can see the thyroid cartilage anteriorly. Just below it, there is the C6. At the level of C6 is the cricoid cartilage. Knowing this anatomy is very important. When we are planning for the surgery, it is important for the, obviously we'll confirm it with the help of the C-arm, but for the, especially for the residents and the undergraduates, it's very important to know these landmarks. That's how you can plan for the surgery. Another importance of knowing these landmarks is at the level of the C6, there are some important events that are occurring, such as the pharynx will now become esophagus down below this level. Similarly, the larynx anterior situated will now become trachea. The other importance of this level marking is at the level of C4, the common carotid is going to divide into internal and external carotid arteries. Now, this is the another picture taken from the Netter. This also giving us the impression that hyoid bone, this is situated at the level of C3 vertebrae. Similarly, at the level of C5, C4 and C5, we can see the thyroid cartilage anteriorly. Anterior to C6, we have the cricoid cartilage. Now, going into the deep dissections, once incision is given in the skin, the very first muscle that we are going to see, it is the platysma muscle. It is a platysma muscle. It covers the skin, underlying skin very closely situated. It starts from the mandible, and once we remove the this muscle, the platysma muscle, then we can go into the deeper layers. Before going into the deeper layers, we need to understand there are the cervical fascia, which is divided into 4 separate compartments, starting it from the most anterior one. So for this, understanding these fascias and the compartments, we need to go to the axial or the transverse cut. In this axial or transverse cut, this is the anterior, this is the posterior side. In the anterior side, just as we remove the skin and the platysma muscle, now we are going to see the investing layer of deep fascia. This investing layer of deep fascia is going to cover 2 important muscles, sternocleidomastoid muscle anteriorly, and at the back it is going to cover the trapezius muscle. Here we can see this is the blue colored fascia investing layer, which divides at 2 parts, covering 2 important muscles, sternocleidomastoid muscle anteriorly and the trapezius muscle posteriorly. When we go deep into it, now we can see 2 different compartments here. One central portion, which is covered by the pretracheal fascia, which is going to cover the larynx, trachea. Along with it, there is going to be thyroid gland as well in this layer. Just lateral to it, there is the carotid sheath, which is going to cover important neurovascular bundle, that is the common carotid artery and the internal carotid artery superiorly. And just on the lateral side of it, there's the internal jugular vein. And at back, there is the vagus nerve. When we go even deeper dissection, after going into the deeper structures, we can see around the vertebral body, there is another fascia, important fascia. This is the prevertebral fascia, which covers the vertebral body and all important prevertebral muscles that we'll discuss and in detail later on. This is diagrammatic picture to make it easy. Again, starting from the anterior most portion, we can see here this purple line, we can see that is covering the tracheal region. Along with it, there is the thyroid gland. This is the pretracheal fascia. And this green one, as we follow laterally, it is covering sternocleidomastoid muscle. And at the back, it is going to cover the trapezius muscle here. The red one here signifies the carotid sheath, which is covering three important structures: internal jugular vein, laterally placed, internal and common carotid artery medially placed, and at the back there is the vagus nerve. The sympathetic chain runs at the back of it. And as we go back towards the vertebral body, there's the prevertebral fascia, which is covering all the muscles, important muscles, prevertebral muscles. This is another important, beautiful picture taken from later, which is showing us these fascias as we look them from the anterior view. As we can see here is on the left side of the screen, the sternocleidomastoid muscle is here completely covered by this fascia, the investing layer. And when we go deep to it, this is the pretracheal, and just at the back of it, there is going to be prevertebral fascias. Here the muscles are naked from the fascias. Now coming to the triangles of the neck, the sternocleidomastoid muscle divides the neck into two triangles, the posterior triangle and the anterior triangle. Let's start it with the posterior triangle. The posterior triangle is bound anteriorly by the sternocleidomastoid muscle. At the back, it is bound by the trapezius muscle. And below, it is bound by the clavicle. So this posterior triangle is very important, as there are few important structures that are passing through it. One of them is the accessory nerve, as shown here. Secondly, it contains the lymph nodes. The roof of the posterior triangle, it is formed by the investing layer, whereas the floor is formed by the prevertebral fascia. The structures, important structures that we are talking about, the accessory nerve or the brachial plexus and the cervical, even the cervical plexus, all will be covered by the prevertebral fascia. The subclavian artery also passes through this triangle. As long as we have not pierced the prevertebral fascia, all these structures would be safe, whereas the lymph nodes lie superficially in this posterior triangle. When we talk about the anterior triangle, it is again divided into four different triangles. Now, it's a bit complicated concept, but it is very important to understand that this anatomy, because of the important structures that are lying in these specific triangles. So let's start it from the most superior triangle. So it is bound superiorly by the angle of mandible. Anteriorly, it has the digastric, posterior belly of the digastric. It lies between the two bellies of the digastric muscle, anterior and the posterior digastric belly, and superiorly it is bound by the mandible. So it is known as the submandibular triangle, and the importance of submandibular triangle is submandibular gland lies in this. Anterior to the digastric belly, this is the small one, this is the submental triangle. And there are important lymph nodes lying in this submental triangle. As we go down below, there are two triangles now bound, the carotid triangle. The content of the carotid triangle is the carotid sheath, along with it the carotid, the contents of the carotid sheath. It is bound posteriorly by the sternocleidomastoid muscle. Anteriorly, it has the omohyoid muscle. And anterior to it is the muscular triangle, which is bound posteriorly by the omohyoid muscle. In middle or center, there's the central portion of the neck, and inferiorly, it has the sternocleidomastoid muscle. The strap muscles are lying in this important triangle. The strap muscles we'll discuss later on. This is the same posterior triangle that we have already discussed. Now coming to the strap muscles. The strap muscles, as we go deeper into the dissection of the neck, after the superficial muscle, that was the sternocleidomastoid muscle, when we go into the deeper planes, Now there are the strap muscles which are completely covering the neck. The important structure here is the hyoid muscle. There are four important muscles that are lying superior to it: mylohyoid, genohyoid, stylohyoid, and digastric muscle. And four muscles are lying or binding it to the lower side. That are the sternohyoid, thyrohyoid, omohyoid, and sternothyroid muscles. So this picture shows here, first of all, locating the hyoid bone in the center, as we can see it here. There are four muscles that are arising or getting attachment to the hyoid bone. The centralmost muscle that can be seen here, it is the sternohyoid muscle that binds the hyoid with the sternum. When we peel it off, we can see two important other muscles, that is the thyrohyoid muscle, which connects it with the thyroid cartilage. And then there is the sternothyroid muscle, which connects the sternum with the thyroid. So this is the thyroid cartilage. Here we can see the muscle that binds the hyoid with the thyroid, that is the thyrohyoid muscle, and one muscle that binds the thyroid with the sternum, that is the sternothyroid muscle.
Babar, we are not able to see your screen. Can you is everybody able to see the screen?
Yes, we can see the screen, Professor.
Okay, somehow I'm not able to see the screen. I can see Dr. Babar presenting. Okay, go ahead. Maybe it'll be displaced again.
In the upper right corner, Doctor, you can see there is the icon. Maybe you can press on it to change the view.
Shall I continue?
That's fine. Yes, please go ahead. Now I can see it. Yeah.
Okay, sir. Thank you. The fourth and the very important muscle here is the omohyoid muscle. We know the importance of omohyoid muscle. This is the muscle that we retract medially while going for the ACDF. We are going to see the plane of ACDF as being a neurosurgeon and dissecting down the anteriorly the neck. It is very important to know the location of the omohyoid muscle. Omohyoid muscle, it has two bellies. The anterior belly and the posterior belly, which is going at the back and will get attachment at the scapulae. Similarly, there are four important muscles that arise from the hyoid and that get attachment superiorly. One of them is the digastric muscle. As we know, it has two bellies, anterior and the posterior belly. Just more deeper to it is the mylohyoid, which is making actually the floor of the mouth. This is the mylohyoid muscle, gets attachment at the hyoid as well. And there's the stylohyoid muscle, which will get attachment at the styloid process at the back, as we can see this strip of muscle here. And genohyoid is going to connect the hyoid with the tongue. As we go more deeper, we can see here the once we have removed all the muscles, now we can see the deeper structures here, starting with the thyroid larynx, that is the thyroid cartilage, cricoid cartilage, and as we discussed at the level of C6, it is going to become the trachea, which is going to divide at the angle of carina and the thorax into two bronchi. Anteriorly, the trachea is covered by the thyroid gland, which covers it. The isthmus covers the second to fourth tracheal ring, whereas till the sixth tracheal ring, it is laterally covered by this important structure, that is the thyroid gland. Okay. When we go further deeper, we can see the neck is supported by a very thick bundle of muscles, which are posteriorly located. These are the extensor muscles, whereas anteriorly it has deep flexor muscles. These important muscles are longus colli, longus capitis, rectus capitis anterior, and rectus capitis lateralis. Let's see them in this picture. Rectus capitis anterior binds with the arch of the C1, whereas at the transverse process there is the rectus capitis lateralis. Both are important for flexing the neck. Then the other important muscle here is the longus colli muscle. The importance of longus colli muscle is that as we go deeper into while doing the ACDF, we are forming the corridor, and just about when we reach the vertebral bodies, before that, this is the longus colli muscle that we need to dissect around 1 centimeter. Close to it is the sympathetic chain, so we need to be careful. We do not want to dissect it more than 1 centimeter, and this is the opposite side of the longus colli. The landmark is very important when we reach the vertebral body while doing the dissection. Now again, revising the complete look of transverse section of the neck. So starting it with the most anterior ones, the anteriorly located are the sternocleidomastoid muscle. At the back, there will be strap muscles. When we go deeper to them, we'll see the thyroid gland. Back of the thyroid gland, this is the larynx. Below, it is going to convert into trachea. Just at the back is the esophagus, which becomes superiorly pharynx. Below, it will become the esophagus. Laterally situated is the carotid sheath containing three structures, vital structures. The carotid artery situated medially. Laterally is the internal jugular vein. At the back, there is the vagus nerve. When we go deeper to these structures, we are going to see actually the vertebral body. In the vertebral body foramina transversum, we have the vertebral artery. And at the back, then there are going to be the important extensor muscles. This is the actual corridor that is formed during performing the anterior cervical discectomy, in which we have to retract these important structures: the omohyoid muscle, the trachea, and the esophagus. All will be retracted medially, whereas laterally we are going to retract the carotid sheath along with its contents. And just at the deeper structure, as we discussed, this is the longus colli muscle. These are the two longus colli muscle that will be retracted to expose the vertebral body and to perform the intervertebral disc removal. Now coming to the posterior aspect or back of the neck. Now back of the neck, important structure here to identify that is the ligamentum nuchae that connects at the occipital protuberance and goes back in the center, and it is attached with the multiple tubercles in the cervical region. It gives insertion and origin to important muscles such as the trapezius muscle. And when we go deep to the trapezius muscle, we have the splenius muscle, which is again divided into two bellies, the splenius cervicalis and the splenius capitis muscle superiorly. These are few important muscles that are situated at the back of the neck that we dissect while going into the back of the neck. Now there are important structures. We'll not go into the details of it. So trachea, just we need to know that it starts at the level of the C6 vertebrae, and it is covered by the thyroid gland in the center. Coming to the important artery, the artery in the neck, that is the carotid artery. As we know that the common carotid artery on the left side, it arises from the directly from the arch of aorta, whereas on the right side it arises from the trunk. Now this common carotid artery runs in the carotid sheath, and at the level of C4 vertebra or at the level of thyroid cartilage, it is going to divide into internal and external carotid artery. External carotid artery will move out of the carotid sheath, and it is going to give its branches important branches in the neck and go to the face, whereas the internal carotid artery will continue in the carotid sheath inside the brain, to supply the brain. These are the veins that are formed in the neck. The important one is the internal jugular vein, which is the continuation of the sigmoid sinus. And now this jugular vein will receive a number of tributaries here in the neck. It is situated deep to the sternocleidomastoid muscle, running along with the internal carotid artery in the carotid sheath. The important cranial nerve, that is the accessory nerve, that arises from the upper 3 or 4 cervical roots, and it is going to go inside the brain and will form the accessory cranial nerve. Similarly, we can see in the neck, in close relation with the submandibular gland, there is the hypoglossal nerve, which will go and supply the tongue. The other structures, nervous structures, the cervical plexus and brachial plexus will also form within the neck. That will be discussed in detail later on. Now, coming to the cervical spine, the other half of the today's topic is the cervical spine. In the previous lecture, Ma'am Abida discussed in detail the C1 and C2 vertebrae in the craniovertebral junction. So I will directly move on to the subaxial spine. So this is the C1 structure. Just giving a quick revision. So C1 and C vertebrae. C1, it has no vertebral body. It has the anterior arch and the posterior arch. C2, the vertebral body of C1 that has fused with the C2, that forms the odontoid or the dens, as we can see in this picture. Another important event starting from the C2 vertebrae downward is that the dorsal process here would be, from here on, it will be divided into two. It is the bifid type of the spinal process. Now, this is the typical cervical vertebrae. Starting from the anterior-most portion, this is the vertebral body connected via the pedicles to the transverse process, the short transverse processes, and to the lamina, and coming to the dorsal process, which we can see here. It is bifid type of the spinous process. The other event that is occurring here, it is the transverse process here. It has a foramina for the passage of the vertebral artery, which passes through C6 till the C2, and then it becomes superficial, runs on the back of the C1 vertebra to finally enter into the inside the brain. These are certain comparison points between the cervical, thoracic, and the lumbar vertebrae. Talking particularly for the cervical vertebrae, it has small and oval-shaped vertebral body, and the canal here, it is a larger one, and it is said that 1/3 is covered by the spinal cord, 2/3, so it remains free. So it is quite spacious at the level of cervical vertebrae. The vertebral foramen here, it is triangular in shape. The transverse process has the foramina for the passage of the vertebral artery, whereas the spinous process are fork-shaped and bifid type, starting from the C2 till the C6 vertebra. This is the look of the vertebral column from the back. As we can see here, this is the passage of the vertebral artery starting at the level of C6. At the level of C2, it is going to become superficial and going to run on the back of the C1 vertebra. Identifying this this vertebral artery is again very essential when we are performing dissection posteriorly to save the any type of damage to this vertebral artery. We can also see the nerve roots that are arising, and in the cervical region, see one nerve root arises above the level of the vertebra, and the rest are going to arise above the same numbered vertebral level. As we can see here, C2 is arising above the C2 vertebrae. So thank you so much. These are certain resources from where I have ma'am, we cannot listen to you.
Thank you very much, Professor.
You need to unmute Dr. Pranita.
Now it's okay. Thank you. Thank you, Doctor. Can you hear me now? Hello?
Yes, we can.
Oh,
we can.
Okay. Thank you, sir. Thank you, Dr. Babar, for your descriptive anatomy about the neck and subaxial cervical spine. So, brief introduction about our expert and the chairperson of today's session, Professor Dr. Asif Bashir. He is the renowned neurosurgeon, an American diplomat, and he has an extensive experience in the complex cervical spine and neurological disorder. So, sir, I have to welcome you at the start. So we just started earlier. So I welcome you in this session, and also we need your expert insight about the subaxial spine. I mean applied anatomy about the subaxial spine. So I mean you have a lot of levels, just like you are the executive director and the professor, and I think you are the member of the WFNS as well, as I know.
Great. So thank you, Dr. Famida. So very nice, Babar. So I think when I look at it, and I tell all our residents, faculty also, you know, every time, whatever you do, you want to simplify it. Why are we learning this anatomy, right? What are we looking for, which we can do, which we can preserve while we're doing this dissection? A couple of points I'll give you over with my life experience, and you keep on learning as you go. Probably have done hundreds of these, but let's talk about anterior cervical approaches. So, a couple of things, you know, other than the complications, you always want to think of what at every step as you are going through. As you're starting, we always do a linear horizontal incision, very small incision, not even an inch. But the one caveat I would suggest to all of you, the youngsters, is that you don't want to place your incision close to the sternocleidomastoid, as close to the midline as possible. So what I do is, I don't even look at, you know, what the landmarks and all that, because you can do up to 4 levels through a same horizontal incision, just like you would do a carotid. So put just a full, you know, right in the center, because the more medial you are, the more avascular plane you will stay in. So as you start the incision, you dissect through the platysma, you don't even need to feel for the carotid or see the carotid. In avascular, so as medial as possible, medially on one side, I always do a right side incision. You would want to retract your esophagus towards the left side, your carotid and the carotid sheath on the right side. But this is your most avascular plane. So stay as medial as possible. I made a couple of points on this. And as you are going, especially in revision surgeries, I think this becomes even more important wherever the incision. So, secondly, don't do a lot of retraction because the retraction also, I think, puts a lot of pressure If you have to do long surgery, you can always retract your flowers, your retractors, and then bring them back again. Don't put them under a lot of pressure as you're going. And always be careful of the sympathetic chain also. As you're drilling, you're doing an anterior cervical discectomy on an artificial disc or a fusion, you're always think of why you're doing this. You're doing this for radiculopathy. Maybe you're doing it just for myelopathy. If you're doing it for a nerve root issue, you always want to drill the oncovertebral. The nerve is going supralaterally, right? So you want to drill the nerve or take a curette and try to follow the nerve laterally, which is called a femorotomy, right? Also, if you're doing through the anterior, having a dural tear is a no-no. So bring a microscope in. Sometimes a lot of people do through the loops also, but a microscope really gives you a better magnification, safety. The difference usually between orthopedics and neurosurgeons is that we always want to open up the OPLL, posterior longitudinal ligament, and as you're finding a glistening cord, that is where you would start having your decompression laterally. So stay in the midline. Couple of risk points, right? So recurrent laryngeal nerve, you've got to be cautious about that. That can give you hoarseness. You can have if you damage the sympathetic chain, you can cause Horner syndrome. Vertebral artery is a no-no event. I don't even think, other than once, we've ended up into. So don't go lateral. Or medial is your game, right? Esophageal perforation is another thing. If you do get one, which is also a no-no event, you want to call help. Call ENT. Have somebody come and repair that with you. Always call for help in that case. But these are the main salient points. So don't look for the carotid. You can feel the carotid sheath, but don't go looking after that. Sometimes you're going that, and you may find a common facial vein, so you can tie between two sutures and tie it and divide it. But staying again and again, staying medial. Find your plane, avascular plane. It has to be without any blood. This is a surgery which you don't need any blood transfusion. You don't need any any damage, which as long as you stay in the correct plane. So I think these are the pearls which I wanted to give to you. I made all these small points as I was going through the anatomy. It was a good learning experience for me also, revision of anatomy. So thank you, Babar. You did a wonderful job. And are we allowed to take questions also, Dr. Ahmed?
Yes, if anyone have questions, please you can go ahead.
Anterior cervical surgery, people think that it is straight, but I think this is the most dangerous surgery if you don't do it the right way. It looks very simple, but it is a high G, it is a high, you're going through all these, vascular injuries, esophageal injuries, all the more important structures are in this. So you always need to know the anatomy. Anatomy, if you know your anatomy, you will be just fine. So keep every step that can cause any damage. Yes, please. Any questions we can take?
So thank you, sir. We don't have the questions yet. And thank you for your expert opinion. Sir, I have a question that you said that according to your opinion, you are doing the midline, you prefer the midline incision as compared to along the sternocleidomastoid muscle. So in your setup, do you have any study that shows that there are the good chances or good prognosis and the less complication in the medial approach as well as compared to along the sternocleidomastoid muscle?
So you're talking about a sternocleidoid straight incision, like a vertical incision, like we do for carotid.
So
right?
just like we do an oblique incision along the border of the sternocleidomastoid muscle.
No. And so it's an oblique incision, but it's a sort of a horizontal incision. You find the best skin crease. Cosmetically, you want to be in the skin crease, right? It's a horizontal, slightly oblique. But what I mean by medial is you want to go towards the midline because that's where the most avascular plane is. So if you are more lateral, I think you're going to damage the sternocleidomastoid. You don't need to get into the sternocleidomastoid. All you have to do is lift up the platysma, use the bipolar, divide the platysma, and then you do your finger dissection, and you should be going all the way down to the prevertebral fascia. But the more medial you are, incision doesn't have to be more than 10 centimeter, 10 millimeter, right? It's like a very small. And then you can do 3 levels also. It all depends how much subplatysmal dissection you have done. You want to dissect the platysma up and down. The skin incision doesn't matter. Skin incision can be, all you need, the skin incision has to be about where you can put your retractors in, right? Put your, whatever system you're using, Trimline or Medtronic or whatever system, Plywood, what you're using. But the real key is to have very generous subplatysmal. If you want to do 3 level, like a C4 to 7, or you can even do 4 levels from here. But the subplatysmal dissection is which will give you all that room to work above and below.
Okay, sir, got it. Thank you, sir. And sir, any comparative study in your department has done on this approach?
Comparative to what?
Comparative to the traditional incision.
This is a very standard. This is a very standard incision. I think there are many publications on that. This is a. I've never seen anything but a horizontal incision, a small along the since 1990s, since I was a resident. So I think that's a traditional. This is also a traditional established way to do it. When you do a carotid, like you're doing a carotid endarterectomy, right? So we do a fair number of that. That's where you go along the sternocleidomastoid, right? So in an oblique incision. So that's only because you need more room. You need to. There also you have to divide the platysma and find the carotid sheet and all of that. That's why you do a little. But I've seen some of the vascular surgeons do horizontal incision even for a carotid endarterectomy, just using about 2 inches incision. So that also works out. Whatever way you're comfortable, I think that's way. But cosmetically, a curved using in the skin crease is the best way to do this.
Okay, sir. Thank you. Thank you so much. Sir.
Any other questions which we can have?
Sir, still I can't find a question from participants. So.
By the way, we encourage. I'll give you, while I have you, we've started this thing that we are allowing sort of a rotation. Any of the neurosurgeons, I think, who are out there currently also, we have 4 or 5 of them rotating this week, are welcome to come and spend 3 to 4 months with us, seeing all types of surgery. So we welcome this to our international, German, Middle Eastern, we have an Italian neurosurgeon. In fact, Dr. Tamara is already online with us. She's faculty at University of Milan, and she's with us these days. So everybody is welcome to come and visit us and see all types of variety of cases which are being done.
Thank you very much, Professor, for this kind invitation, and we will arrange with you to see.
Yes,
you
most
can
welcome.
send some of the residents. It will be a great honor for us.
Yes, most welcome.
So, sir, how can they apply? Is there any, procedure?
Yes, there was on the PSN group also.
Yes, sir, there is.
Dr. Zubair, who's our program director, has been screening them, and we are allowing everybody. We don't select. We said everybody's welcome. So some people will come in a few months, some people will come later, but this tradition will keep on going.
Okay, sir. Professor. Thank you so much, sir. Thank you. It was a privilege having you. Thank you. So, should we continue, or I think
if there is more questions,
we can end. No, still no questions.
I think we are done then. It looks like everybody knows everything, right?
Everything.
When you don't ask a question, that means either you know everything, or my boss
you know nothing. No, nothing.
But I think everybody knows this.
No, yes, sir.
People are well
You know.
prepared these days.
And also Dr.
I see a lot
Babar,
of people had attended.
also Dr. Babar, he did a very good job. He presented his presentation very excellent and was very informative. So everything was clear, I think. So there is no much questions,
Thank you.
as I suppose.
Thank you. So
Thank you so
with
much,
this,
sir.
we
Okay.
can,
Thank you.
we can
Good
end
evening.
our
Good
section
night.
and good. Have a great day.
Let's see, Manal
I
Khan
see
is
Dr.
she's
Manal.
raising hand.
Dr. Manal has raised
Uh-huh.
a question. Yes.
I can't see.
Hello.
How are you, Dr. Manal?
Hello, welcome, Dr. Manal.
Hello, Assalamu alaikum. So, thank you for this opportunity first. This was a very nice session, I would say. I have one question that I want to ask my seniors. What is your take while deciding about the, ACDF procedure, whether to use the conventional cage method or the zero profile? So, what's your take on that?
Manal, I think I'll go ahead and answer that. So I'm very happy that Manal has raised her. And I tell all our residents that the key to showing your presence is to ask a question. If you have not asked a question, that means you were not there. This is my golden rule. So, Manal, the question to the answer is, it's a very standard now studies out there, there are papers out there which have a long-term now follow-up on arthroplasty versus fusion. This is your question. So even a two-level fusion, initially the single-level fusion versus an arthroplasty, there was very promising data to prevent adjacent level disease. Arthroplasty had better results. I've been doing it for over a decade now. In Pakistan, we have limited supply of these arthroplasty and it's more expensive. But in US, when I'm operating there, we always prefer to use an arthroplasty. Now, zero profile is as close to a Medtronic artificial disc or a Mobi C Zimmer arthroplasty. Here you just have to put in two screws, which are superior end plate and the inferior end plate. So adjacent level disease is definitely prevented by zero profile arthroplasty versus a fusion where you put a plate, because that puts extra stress on the superior and the inferior end plates. So that's the answer to that.
Right, sir. Thank you so much.
We have Dr. Musharraf Khan. He also has a question.
Yes,
Please, Dr.
Musharraf.
Dr. Musharraf.
See?
Let's see.
Can we unmute him?
Just looking for him. Yes. Dr. Musharraf.
Hi, sir. First of all, thanks to all the seniors for providing us such an opportunity. Sir, my question is about the forum anatomy. As you told us that, we have been told that the lateral limit for dissectomy is the uncovered vertebral joint. So, can you please guide us about the forum anatomy? That how should we do that? Normally, we just go and remove the disc, and we don't go for the nerve root in the cervical spine.
So most surgery which you're doing. So I'll give you an example of yesterday and today. We did about 4 of these. I'm talking about so we did a posterior cervical. You can call it endoscopic or MED. So that is mostly for radiculopathy, right? When you have pain in a certain C6 radic or a C5 radic. So there are 2 ways to do this. Very few people in the world do posterior cervical femonotomies and all that. I think that is an outstanding procedure. You can use an endoscope, you can use a microscope, you can use a 12-14 tube. But when you're doing it from the posterior, you want to open up the foramen. And you can see that when you do a femonotomy posteriorly, imagine you're doing an open lami first and then following the nerve laterally as it's going into the foramen. So you want to unroof the foramen with the carousons or a drill. But then if you want to remove the disc, here in this case, unlike a lumbar, you elevate you move the nerve up superiorly, and then you find the disc underneath, right? So put a small pen field underneath or something, and you can scrape out the disc or open up the disc through there. Now go back to the front. As you're doing a anatomy from the front, imagine the same what you saw from the back side. So the nerve is going laterally and it's going superiorly, right? Anterolaterally. So what you want to do is either you use a drill initially, and then the safest thing is you use a curette, an upgoing curette, and scrape up the lateral foramen along the ancovertebral joint, and use a number 1 or a number 2 kerrison and bite it at a 45-degree angle up, either side, whatever side you're doing the foraminectomy on. Well, people will caution you that, we'll start having bleeding and more. If you go more lateral to that, that is when the venous oozing starts. Even if you have oozing, we didn't talk about hemostasis. The best way to control oozing, as you go more lateral, is don't worry about it. Just do pressure irrigation. If you do irrigation, quick, fast irrigation under pressure, that bleeding will stop. This is just venous. So foraminectomy, anterolaterally with the kerrison and the curette. Don't use the drill too laterally, because sometimes you can damage and go into the vertebral artery. Sometimes you can have an anomalous vertebral artery which is medial. So that's one thing to caution. Okay, so.
Right, sir. So thank you.
Thank you.
Any other questions?
There is one question in the chat from Dr. Abdul Karim Mansour. He asking, what are the intra-op signs in anterior approach that alarm us that there is esophageal injury?
Yes. How you would, who's asking this question?
Dr. Abdul Karim Mansour.
Okay, so you guys know how the most of the esophageal injury happens? So esophagus, if you're coming from the right side, esophagus is more towards medially, right? And most of the time, the esophageal injuries is a covert. You don't find out, right? Later you find out, the patient is having difficulty with first of all, we did mention about swallowing difficulty also. But if you do find out the esophageal injuries, and while you're doing it, you will see sometimes a tear in the lateral part of the esophagus, in the outer surface of that. So if you see oozing coming out of there, or if you see a tear, sometimes you can see sort of discharge coming out of that. You just call for help, call for ENT, have somebody, and you can just sew it up. In a couple of times we've gone and helped also people, because we are more proficient than most of the other surgeons doing anterior approaches. So you just sew it with the Prolene, just like you sew a carotid with a small, but then always put an NG, leave a patient NPO. All these things are important, but threshold, thinking about esophageal injuries if you do it with a drill. So a drill has to be used very carefully.
Thank you, Professor. Is there anyone else have any questions?
Somehow I can't see the chat. There is some. Dr. Abdullah?
And just like you're doing an esophageal injury, you should always be worried. This is why I always say, don't look for the carotid. As neurosurgeons, we should be comfortable taking care of the carotid also. But you can feel with your fingers, feel for the carotid pulse if you have to. But the retractor has to be, this is why the retractor has to be when you're dissecting the longus coli on both sides. You have to place them under them, not over the longus coli, right? Otherwise, you can injure the esophagus as well as, and always use blunt retractors. I don't like to use the sharp retractors at all. And always put distractor pins, because that will also give you distraction superior and inferior. Yes, what is the last question? Let's take one more. And
somehow I can't see the questions in the chat box.
Okay, wonderful. Looks like
thank you, sir.
This was a good engaged session.
So we have enjoyed a lot and learned a lot from you. This was a very valuable insight about the uh, applied anatomy and the surgical approaches. I think while describing these approaches, it's better to observe and do it. Then you better understand it. Even if you are explaining very well, but somehow if you are not encounter these surgical approach and haven't seen such procedures, then it's quite difficult to understand all these things. So as you are providing them the opportunity, so it's a good come and observe these procedures so they
Yes, you
can
come and
learn.
observe.
Yes,
You
sir.
come and observe, but I'll tell you one thing, all the youngsters, and my teams know about it. By just observing, you will not become a surgeon. You have
Yes,
to, you follow
agreed, sir.
the
Agreed.
US model, which is you see one, you do one, you have to teach one. So you have to scrub in to be able, and unless you do one, this is an approach where you should not have any complications from the front. But if you have one, this is where you learn. I still remember the first few ACDFs, anterior multi-levels I did. I remember one patient had bad swallowing difficulty and hoarseness, and I still remember that hoarseness did not improve. So next time I did that, this was a 3-level. I was more cautious about the recurrent laryngeal nerve as well as the esophagus. So you learn to respect as you do this. So respect the anatomy from the front, anterior neck. This is the most dangerous part of what we do. This is more damage can be done than intracranial surgery here.
Yes, sir. Agreed. Totally agreed, sir.
Thank you, Professor.
Okay, great.
Thank you, Dr. Fahmida.
Uh,
And thank
thank
you
you
very
so
much,
much,
Dr. Ali,
Doctor.
Babar Ali, for this wonderful
Thank you,
presentation.
Ahmed. Thank you for having us.
It's an honor for us to have you, Professor. I
Thank
see
you.
Professor Sayed
Okay.
Shahzad here. If you want to add any remark or any question.
Yes, Shahzad is here also. He's one of our young professors. Shahzad.
Sir, excellent talk, and I'm really honored to be a part of today's webinar and the talk by Professor Asif Bashir. He is changing and he has changed almost everything. So the PINS is on path of real growth, and it will be in coming times recognized internationally to a much higher level. Actually, what really it is. So Professor Sasa basically is doing a lot for PINS and for education, for training. And, he has changed many concepts of us. Previously, which we were thinking that I thought that it's not right, it's not like that. But with them, I learned that he was right, basically. So vision changes things, and I hope so. PINS neurosurgery and then Pakistan neurosurgery will be on better path, and it will be internationally at much higher level. Thank you.
Thank you, Shahzad. And for the young surgeons, one last line from me. I always say that if you're a surgeon, you have to be bold, because luck will, if you want to be lucky, but luck favors the bold. So be a bold surgeon and always ask for help anytime you get into trouble. That is your key to your success. Okay, so best of luck, and we are always available. You all have our number, and everybody's welcome to come and visit us also. Thank you.
Thank you, sir. Thank you so much. It was a nice time with you and your valuable insight about the topic and all these pearls. And so one thing that the people of I think Pins are lucky that you are a good leader as well. So a surgeon, if he's a bold and he's expert, but if he has a good leadership quality, he can lead his team very well. I mean, every surgeon is good in his expertise, but if he is not leading his team, then I think it's not the beneficial. At the end, you will left behind so many experts. They can help themselves as well as for the patient. So I think this should be continued, and everyone should do something to lead his team or his colleagues or his faculty. that's I mean I always appreciate that you have a lot of opportunities and you have the very big setup, but you have also the very big mind as well. So thank you so much,
Thank
sir.
you. Thank you. I think we have one more. Dr. Noor is here. Noor, I saw you had something. Noor, you have a question quickly?
Thank you
Oh,
very much.
welcome, Noor.
Hi, thank you very much. Thank you very much for
How
having me
are
here.
you?
I'm right now in Pakistan, in Lahore.
Thank you. Welcome.
Thank you very much.
How are you, Noor?
I'm doing great. Thank you very much. It was an amazing, I think, a very insightful session, especially for the young neurosurgeon. And anatomy is a very basic thing, like very nicely put down by one of my friends for the surgeon. He said that obviously the spine anatomy is one of the most important things that could be discussed, especially for surgeons. So thank you very much for having me. And of course, I really want to say a few words about Professor Asif Bashir. He's the source of great pride for Pakistan, because being a Pakistani neurosurgeon, someone who has been trained initially here in Pakistan, I feel very honored when many of my friends very nicely talk about Sir. And recently I was talking to some of my friends from Italy, and they were like, they said, please convey our wishes to your professor. He's a very nice person and a very dedicated teacher as well. So again, Sir, thank you very much for all the dedication that you have shown and all the leadership that you have shown through all the years. You are an inspiration for all of us, and obviously a source of great encouragement for the young neurosurgeons. Thank you very much. Just a comment. And thank you very much for the amazing program, and also wishes to Professor Fahmi Damullah.
Thank you, Noor.
Thank you.
Thank you so much.
Thank you all.
It was nice
Have
to
a good night.
Thank
Thank
you.
you,
And
sir.
Okay.
by this, we can
At the
conclude our
end,
session and see you all next Friday, inshallah. Thank you, everyone, for this amazing
Thank
presentation.
you. Good night. Bye-bye.
Good night.
good night. Have a great day.
Thank you, Allah
Thank
Hafiz.
you.
Thank you all participants, and thank you
Thank you,
presenter
Ikram.
as well, Dr. Babar Ali. It was a good descriptive presentation. Thank you.
Thank you so much, ma'am.
Thank you.
Thank you.
See you all. Bye-bye.
Bye.